All right, everybody, so let's move forward. I learned that you can only record for 15 minutes at a time, so here we go. Okay, so barriers to assessment of pain. We started to talk about our nonverbal patient and used Alzheimer's as our example. So patients also with language barriers. We want to make sure we're using our language line so we actually can assess what their pain is accurately. Some of our patients have that mindset that they don't want to bother us, so they don't necessarily ask for pain medication. The other issue here is that patients should be aware if they have a PRN order, right? PRN means as needed medication. You want to empower your patient, like I'd said before, letting them know that they have medication ordered so that they can ask for it. All right, so what are the medications that we've been talking about here? So under our first category, our non-opiate analgesics, we have here Motrin, ibuprofen, Tylenol, aspirin. These are good for mild to moderate pain. And we can remember, right, that our NSAIDs usually have the side effect of increased bleeding, right, because they impact platelet function. So any patient that has a bleeding concern, we wouldn't want to give them an NSAID. All right, the other thing that falls under the non-opioids are our COX-2 inhibitors, and that was our Celebrex, good for arthritic pain. Okay, so then we move into our opioid analgesics. This, for example, we've got codeine. We've got oxycodone. Oxycodone works very similar to codeine. It can be immediately released, or it can be a controlled release, which is Oxycontin. That was the MS cotton from the question before. Another example of an opioid is morphine. The major side effect here is respiratory depression. Morphine can be given PO, IM, IV, sub-Q through an epidural or an intrathecal route. There is a classic triad, so 3 things of toxicity of morphine: a coma, respiratory depression, or pinpoint pupils. Thankfully, we have an antagonist that can reverse this called Narcan. At a vaginal delivery, if a patient was recently given morphine or any medication for pain, we have Narcan on board so that if the baby comes out respiratory depressed, so meaning mom got a medication, went to the baby, we want to make sure that we can reverse the side effects in the baby by giving Narcan. Obviously, in a patient, not pregnant, if they have too much morphine, we can reverse it with Narcan. Important here, if you have a patient on hospice care, end-of-life care, and they have the symptoms of morphine overdose, we are not going to give them we're not going to give them Narcan to reverse the toxicity, correct? If they're on end-of-life hospice care, we would not reverse the toxicity. We would let the patient pass away. Okay, so the final category is our adjuvant analgesics, and I touched on these before. This category is our anti-anxiety, antidepressant medications, also anti-seizure medications. So how does that work? So let's think about this. A lot of patients who have high chronic pain also suffer from depression. So something like tricyclic antidepressants, with the example being amitriptyline or Elavil, E-L-A-V-I-L, those work really well sometimes as adjuvants, so not alone, but in conjunction with an opioid. The other anti-seizure medication examples are Tegretol or Neurontin. Those both work well, especially for neuropathic pain. Okay. Sorry, I just want to make sure I'm going in the right direction here. So our non-opioid analgesics, okay? Actually, no, I apologize. The ladder comes first. Okay, so the WHO analgesic ladder for cancer pain management, or really any pain management here, is that at the first step, which is our widest step at the bottom, we always want to go for a non-opiate, so that would be like our NSAID, and adjuvants if we need it. Then when we move up, we want to get an opiate for mild to moderate pain, and then once we get to our top tier, we want to give an opiate plus a non-opiate plus an adjuvant. So we'd be giving all 3 things together. So again, the bottom is when the patient has the lowest amount of pain, and the top is when they have the most amount of pain. It's important to note that when the opioid is given with a non-opioid, they work synergistically. So that would mean like giving Oxycontin with Tylenol. They work together so that you can give less of the opioid, so less of the Oxycontin, when it's given with Tylenol. So again, they work better than they would alone. All right, so let's move forward. The non-opioids I had explained from the last slide where we had all three listed. Again, just make sure you realize that an NSAID wouldn't be a good choice for a patient with bleeding issues. And then we want to be careful with Tylenol because Tylenol can affect a patient's liver. Okay, so what do we choose for these medications? I went through the WHO ladder just 2 slides ago and sort of walked you through how we pick pain medications, but we want to make sure we're giving an opioid agonist for any patient that has cancer. So these medications doses are titrated depending on what type of pain a patient has. And just remember that a patient's tolerance will increase over time so that the effect of the medication lessens and so that we need to start giving more of the pain medication, okay? I have written here, you want to avoid Demerol in patients. That's really because, especially in older adults, Demerol can cause delirium, so major confusion. When a patient is middle-aged or younger, we can use Demerol for a couple of days in an acute care setting, but Demerol is not a good long-term option, okay? All right, so let's look at this question. Mrs. Martinez is a 46-year-old woman being treated with fluorouracil, doxorubicin, and cyclophosphamide for stage 3 breast cancer. She is having pain 9 out of 10. Would Motrin be a good choice? Absolutely not, right? We obviously go back to that WHO ladder. She has cancer, right? Don't worry about what those 3 cancer medications are. Worry about the fact she has stage 3 breast cancer. We are going to make sure that she has an opioid on board. So morphine would probably be a good choice for her. Okay, so we talked about the route of medications. Something to think about here is that if a patient is on end-of-life care, you don't want to be doing any unnecessary procedures. So giving them intramuscular or an IV, you don't want to give them an injection or have an IV. Morphine through an IV can be really uncomfortable. So you want to think about sublingual or transdermal. Oral is great, but if your patient can't swallow, then you can't give oral. So remember, end-of-life care, be really cautious about the route you're giving it. If the patient's uncomfortable, you don't want to be rolling them over to give them an IM injection in their gluteal. Again, transdermal patches work really well. Some of them you can put on the patient and they last for a couple of days. Again, IV we typically use in the hospital, which I know you guys know. And again, just be cautious of not causing any undue harm for a patient that's already uncomfortable. So PCA, patient-controlled analgesia, that's when the patient has a pump and a button that they can press for a bolus of medication, and there's a lockout on it so the patient can't overdose themselves. But that is a nice way for the patient to control their own medication. All right, so how do we manage breakthrough pain? So breakthrough pain is your patient has medication ordered, let's say every 6 hours, and they get pain starting at that 4-hour mark. What are we going to do? So they still have 2 more hours before they're due for their next dose. So here we want to think about sort of a rescue pain medication. So if the patient has this steady dose, we want to talk to the provider that when they have increased pain, what can we add? So this would be an opioid that has sort of a rapid onset, so meaning it works quickly, right? Just to get through that breakthrough pain. This is really an important thing if we want to think about it as in correlation to asthma. When a patient has asthma, they have their regular medications that they take every day, but then they have that rescue inhaler for when they need it. Think of a patient having their normal pain medication, and then when they have this breakthrough pain, they need their rescue medication for pain, okay? Again, it'd want to be a medication that works rapidly and is out of the system fairly quickly. So rapid onset, short duration. So an example of something like that would be sublingual or IV morphine that just helps quickly. All right, the last actually point before I move forward here is that a drug that has a short half-life, as we're talking about here, the sublingual or IV morphine that's rapidly absorbed and has a short duration, in an older adult, because of their metabolism, the half-life of that drug could look longer in them, longer than it would if it was given to you or to I, okay? And that makes sense, again, because our metabolism is quicker. Okay, so this is just another question. How is breakthrough pain different from end of dose pain, and how might you manage each? All right, so breakthrough pain is that pain that happens mid-dose, so again, in between doses, and can be associated with the patient had an uncomfortable procedure going on in between. And then end of dose pain happens just before they're due for the next dose. So not several hours before. End of dose is, okay, well, 20 minutes before I'm due for my next, I start to get uncomfortable. They're just not quite making it through. They don't necessarily need more medication if it's just, okay, 5-10 minutes before I'm starting to get uncomfortable. But breakthrough pain does need that very short-acting, rapid onset medication. And as an example, if the patient, say, a half an hour before their normal dose gets that end of dose pain, maybe they need a slight increase in their just typical dosing, okay? And typically pain medications are given every 4 to 6 hours. And so if there's a PRN order for every 4 to 6 hours and you are giving it every 6, but Mr. Jones is uncomfortable at 5.5 hours, then we're just going to give it at 5.5 hours. Okay, so all these medications that we're talking about don't come without risks. Thankfully take away our pain, but with a little bit of a cost. Morphine especially causes respiratory depression, but the rest can as well. Constipation is a major side effect of an opioid. Sedation, right, so feeling sleepy, nausea, and vomiting are big ones. So we always give patient a stool softener typically, or even a laxative if they are not going to the bathroom when they're on these medications. All right, so the adjuvant medications I had started to talk about, this again was our amitriptyline or our Elavil, and also our anti-seizure medications such as Tegretol or Neurontin, and again, they work really well with neuropathic pain. All right, so we've got some physical and psychosocial interventions that we can do. So this again is for patients that have mild to moderate pain. We can do things in conjunction with their pain medication. So meaning we can give massage, we can do acupuncture or TENS, which is the transcutaneous electrical nerve stimulation. Apply heat, apply cold. These don't necessarily take away the pain, but they help to alleviate it for a patient. So we do want to make sure that we pay attention to that as well. Something to think of here, the St. Mary's Hospital where I've done deliveries, they have a massage therapist. So postpartum, while a mom is dealing with cramping and uterine involution, meaning the uterus going back down to pre-pregnancy size, which takes about 4 to 6 weeks, when they're experiencing that pain and cramping, they can undergo a massage in conjunction with getting Motrin to help decrease their pain. All right, some other things are relaxation and guided imagery or peer support groups, and we can certainly walk a patient through guided imagery. So who are our special populations when we think of pain medication? So we want to think of elderly adults, young children, or opiate abusers. So let's parse each of those out. Older adults. Some people have misconceptions, right, that older adults don't feel pain the same way or they should be able to tolerate it more. I want you to get rid of these myths. They are not at all true, and we need to make sure that we are adequately treating older adults as well. We know that the half-life of medications, because older adults have slower metabolism of drugs, that the half-life, so the side effects could be increased and the drug is going to stay on board longer, but that shouldn't inhibit us from treating them. So young children, right? If a child can't speak, sometimes we don't know that they're necessarily in pain. So we want to make sure that, we're giving them the right dose of medication, we're assessing them the same way we do adults and older adults, and make sure that they are being treated effectively. All right, opioid abusers. This is a really dicey topic, right? So you have a patient who's been addicted to OxyContin. Now he has cancer. Okay, you cannot judge him for his past abuse. I want you to get that out of your head. We can't say, hey, he's abused medications. I really don't feel comfortable treating him, because that's not fair to his cancer pain, okay? Drug abuse is, so an opiate abuser, somebody who's addicted to pills. It's an addiction, for those of you who are in mental health, is a physical problem, right? It is a diagnosis, much like diabetes or hypertension. These people have a chemical dependency. So we want to make sure that we are not judging them and that we are treating their pain, okay? So the other thing that I want to say about this is if a patient's coming in saying they're uncomfortable, you don't want to just assume that they're trying to get high. You do want to treat them.